Thank you for joining the Red Clinic podcast. I'm Dr. Schwalen. I am a pediatric psychologist and expert in the treatment of eating disorders. Today, we have a very special guest on our show. I'm so excited, Dr. Stephanie Setliff. Thank you for joining us again.
Thank you for having me.
Why don't you just go ahead and tell the audience a little bit about who you are, just real quick,
Okay.
and then we're going to talk about refeeding syndrome.
Okay, that sounds good. I'm Stephanie Setliff, and I'm a child and adolescent psychiatrist by training, and I'm the regional medical director right now for Texas for Eating Recovery Center, and I treat eating disorders at all levels of care: inpatient, residential, partial hospital, and intensive outpatient. So we deal with refeeding syndrome. So I'm glad we're going to talk about it.
All right. So what is it? I mean, I think clients don't necessarily understand that it's even a risk. I will tell you what happens outpatient a lot.
Yeah, tell me.
We'll diagnose an eating disorder. It might be the first time they've ever gotten the diagnosis. And they go home and they'll start eating right away. And I have to literally tell them, hey, just because you got this diagnosis, I don't want you changing really anything until you get your higher level of care assessment. But if, certain things are happening, this is when you go to the ER, that kind of thing. Those are the conversations I have to have, because right away, kids especially, they'll go home and they'll start eating. And I have to really warn parents to not let their child do that unless they're under a doctor's care who really understands refeeding syndrome.
Yeah. And that's so true. I mean, we have that happen where patients are even in a medical hospital waiting to come in to see us when we have a bed, and they're trying to prove to their parents that they don't need to come. Mm-hmm. So they start eating, 4,000, 5,000, 6,000 calories a day. And most of even the nurses and everybody's so excited that they want to eat. So
right.
they tend to want to give them the food, but it really causes a lot of medical problems and can cause them to retain a ton of fluid and make things more difficult for them to get treatment. So how we like to talk about refeeding syndrome is we just like to talk about these two things. So one of them is when your phosphorus starts to fall. It's called hypophosphatemia. And then the other, but you can watch for that. You can do labs for that. You can make sure that it doesn't fall. It doesn't fall too fast. There's ways to manage that. If you never checked it, and I mean, if you literally never checked it because you didn't know that it needed to be checked, that would be called, you would talk about somebody in refeeding syndrome where they would get a critically low phosphorus because they're eating. And then if it still wasn't checked, they would die from that.
Okay.
So in eating disorder treatment, phosphorus problems happen about 45% of the time, not 100% of the time. How you know that it might happen is there's things like this that are kind of common. They've had this happen before when they had to be refed, an extremely low body weight, somebody that has had a lot of purging problems. Those kinds of things tell you that they might be more vulnerable to it. In other parts of the world, not the United States generally, but other parts of the world, New Zealand would be one. One of the ways that people deal with it is that they prophylactically start phosphorus. So anytime anybody's admitted to the hospital, they put them on oral phosphorus that you take multiple times a day to prevent it. At Eating Recovery Center, we considered doing that and just decided not to because it only happens 45% of the time. And checking labs like phosphorus, magnesium, potassium, it's easy to do.
Okay.
So we don't do it prophylactically. We just watch for it and then respond to it. So how you can think about it is that these electrolytes that we're talking about, phosphorus, magnesium, potassium, they live inside cells. So if you think about a cell as big as one of these lights, there's all kinds of things living in them. And when you're having trouble with eating nutrition, what happens is the electrolytes inside the big cell, I have to think about them as really big to kind of visualize it. The electrolytes, your body wants to stay healthy. Your heart, everything in you wants to stay healthy. So it's I've likened it to airplanes don't want to stop flying. It's hard to make an airplane land. It's pretty easy to take off. then your bodies don't want to die. And so it's a normal thing. Our bodies are made to have the electrolytes get pumped out of the cell into the extracellular fluid. And that keeps everything running well. Your heart stays in normal sinus rhythm. You're able to maintain a kind of a status quo. You're not necessarily doing a lot of things that you need for energy for your body in the short run, but you maintain. So if I do a blood draw on a person who's in that position, their phosphorus looks normal. They get a normal phosphorus. They get a normal potassium, a normal magnesium. And nobody really can tell from that they may actually be low on their phosphorus and other electrolytes. So what happens is, because it accommodates, you compensate, you drive, they go out of the cell. When you take in food, so now you're going to come into treatment with me, and you start eating, or you might take in food like in Boost, you might drink Boost, have an NG tube, have it going in your nose, down to your stomach. Your body responds with, hey, wait a minute, this is like energy's coming in. This is good news. I mean, this is really good news. So you start out with normal electrolytes. The treatment can actually make them become abnormal because, so insulin comes out. We got to do something with glucose, right? We've got to get glucose to pyruvic acid, more than you want to know, but it's 10 steps, and all of them use phosphorus. So the insulin gets secreted from the pancreas, and insulin drives the electrolytes back into the cell. So the phosphorus gets driven back in the cell, and magnesium, potassium follows, and all of a sudden your body that on a blood draw 4 hours ago had a normal phosphorus, when you draw it again, it has like critically low or even just lower. But your body is also, the messaging is there's nutrition now. Now I can do things that take energy. So it takes, what you don't realize is that for your diaphragm to move when you're breathing, for your heart to beat, all of that takes energy. It's not a passive situation. And when you don't have enough phosphorus, you can't do any of that. You can't, so your red blood cells start to burst. Your diaphragm won't move. You can see that this is not good. And also there's other major organs that need a lot of energy to function. So, but all you have to do really is have access to a lab to be able to check labs. So if we can check labs, we can check every 4 to 6 hours. We can watch it. It's on the way up or it's on the way down. And it's not life-threatening. It's only life-threatening when nobody ever gets a blood draw. And you have no idea. People are totally asymptomatic. They experience nothing as their phosphorus is falling. And that's why it's so deadly. And the first time we really, really ever understood how bad it was, if you think about the stories that you probably heard about, when the Allied forces liberated the prisoners in World War II, and you've seen the pictures of the cachectic prisoners. So they liberated them, and they had a lot of food with them, and they gave it to all the prisoners. And the prisoners then got on train cars to go to wherever they were going to be reunited with their families or go to the hospital, et cetera, et cetera. When they opened the train cars, all of them were dead because they had eaten a bunch of food. Nobody was on the train car, let me just say, checking phosphorus levels. Mm-hmm. And because they were starving, and so they went from nothing, eating nothing, to what we were just talking about, to eating everything that they had. So it was devastating for the people that had liberated them. And one of the things that they noticed was that as the Allied forces marched through and liberated prisoners further away, they had less food with them. And those prisoners lived because they ate less food, right? There was a doctor that was really just so upset by it. He wrote about it in a journal. I mean, really, this was helpful at figuring it out. He wrote about it in a journal, and it was found, I think, after his death. What he wrote was that he thought it was interesting that the prisoners that had been given chocolate milk and chocolate bars had survived and fared better than the prisoners that didn't get any. Ding, bada ding. Mm-hmm. Chocolate has phosphorus in it. So that was kind of really the beginning of realizing how important it is to keep your phosphorus levels within the range of what we call normal.
That's so interesting. And so if there are pediatricians maybe out there or physicians that don't necessarily have this on their radar either, they're not going to think to check labs if they're prescribing more protein bars.
Yeah, they're not going to. I mean, but what you said at the very beginning of this is so true. If somebody is really, really sick from an eating disorder, even though it makes no sense in a common sense way, the last thing we want them to do is go eat 4,000 to 8,000 calories to show their loved ones that they don't need treatment and they don't need to go to the hospital and they really can eat.
Right.
It is the last thing we want.
Right. And that's exactly why we have that conversation with clients when they're leaving our office, and I'm not going to put them on our caseload because I know they're appropriate for a higher level of care. And I'm going to say, just keep doing what you're doing.
Right.
Don't increase how much you're eating until you get under a doctor's care that understands this.
Right. And you just have to help the parents because children do want to go home and show their parents.
Right.
And then there were different things that have happened. Another issue that happened that kind of highlighted how important phosphorus is, TPN was really first discovered, I think it was first used in like the early 1960s. And it was a hospital in Pennsylvania. There were burn victims, 8 of them. And so they were given TPN, which is nutrition. Doesn't sound like it'd be very comfortable or good, but it's essentially nutrition that goes through a central line that's placed. And everybody was so excited because it was a way to give nutrition to people that couldn't get it any other way. And what turned out was that, once again, they didn't know to check electrolytes, and all 8 of those people died that night. And they started, I think, on Wednesday afternoon, and then the next Thursday, all of them were dead because they had their phosphorus was not, there was no detectable phosphorus in their bodies. So, it's not just phosphorus. You have to watch for potassium, magnesium, other electrolytes can play a big part in it. But at least with potassium, when potassium's low, people will complain of cramping,
There's
legs.
a symptom there.
Right. With phosphorus, there isn't one. You just have to know that you've got to check it.
It's just like very silent and deadly. Mm-hmm. Wow. Well, thank you so much for explaining that. I think it's super helpful to our audience to understand that eating disorders truly have true medical complications associated with them. And they really need to make sure they're touching base with professionals who understand how to help rather than trying to just manage it on their own.
Yeah. Yeah. It's really true. It's really true. So thanks for having me.
Absolutely. I hope you join us again. Thank you. And there you have it. That's the Red Clinic Podcast. See you next week.